Hello everyone, in this lecture we will be going over diabetes mellitus. For the objectives, your goal is to understand the different types of diabetes that are diagnosed in the pediatric population, to be able to recognize signs and symptoms of hypo and hyperglycemia, and then also get a good understanding of the treatment and management. Starting off with the endocrine system, the pancreas. So this has two purposes. The pancreas can function as an exocrine gland that helps with digestion, and it also functions as an endocrine gland where it produces hormones to help regulate blood sugar. So that's what you want to focus on when we are going over diabetes. So in the pancreas, it has a cluster of cells called the islets of Langerhans. They produce different hormones to maintain that balance of glucose. So think of it as a hormone factory. Within that hormone factory, it has alpha, beta, and delta cells. So the alpha cells, it produces glucagon. Glucagon, it acts as an alarm clock for the liver. The liver stores glycogen. So glucagon wakes up the liver and tells it to break down glycogen into glucose and release it into the bloodstream. Beta cells, they're the key makers of the hormone factory. They produce insulin. So insulin is what allows glucose to travel from the bloodstream and enter into the cell. And that process lowers blood sugar levels. So beta cells, being the factory's key makers, they produce keys, right? Those keys are insulin to open the doors. So when glucose is floating in the blood, they can't get inside the bodies of the cells on its own. They need that insulin key to unlock the cell doors so that the sugar can go inside and be used for energy. So for those with type 1 diabetes, the key makers, the beta cells, they're on a permanent strike in the hormone factory. So the doors stay locked. Therefore, the sugar gets stuck in the blood, and that leads to hyperglycemia. Lastly, delta cells. They are the hall monitors of the hormone factory. They produce somatostatin. So this that regulates and balances that production of insulin and glucagon. So them being the hall monitors. So if beta cells or alpha cells, if they're working too fast or they're getting too loud in that hormone factory, the delta cells will step in and say, slow down, and inhibit, that release of both insulin and glucagon. So blood sugar doesn't swing too wildly, in either direction. Pediatric variations. So the approach to care of children diagnosed with diabetes, it differs compared to adults. It can vary a bit. So they're always in that constant state of growing and developing. So within that process, growth hormone, it naturally works against insulin. And insulin requirements, it'll fluctuate frequently. So especially during those rapid growth spurts, like during puberty. So puberty, it can be challenging for glycemic control. That surge in sex and growth hormones, it can cause insulin resistance. So often during this period of time, it requires higher doses of insulin within the regimen. Diet and activity. So toddlers and younger kids, they're notoriously picky eaters. And also they have lots of energy. They'll have bursts of physical activity. So it can be challenging to match those insulin doses with what they're actually eating, their carb intake, and how much energy they're actually exerting, on a given day. Hypoglycemia unawareness. So younger kids, they lack that ability, that cognitive ability to recognize and to also communicate those classic symptoms of hypoglycemia, feeling shaky, sweaty, dizzy. So as nurses, educate parents to recognize those subtle behavior cues, sudden tantrums, crying, extreme lethargy, to prevent hypoglycemic episodes. And then dependence on others for care. So school agers and younger, they're completely dependent on parents for the management of diabetes. They're not going to be able to count carbs, check blood sugars on their own, draw up and administer insulin safely. That's why within the management, it's a family centered approach, getting parents or caregivers involved. Think about school and daycare coordination as well. So being able to actively coordinate not only with family but at home, but also with, think about school nurses, teachers, coaches. So making sure that the child is safe throughout the day. So that needs to be incorporated within the care. And then also transition of care. So as the child grows into an adolescent, being able to put that responsibility and having the adolescent take over all those cares. Diabetes mellitus. So that basically just means that the patient is experiencing some type of problem with insulin. This is one of the most prominent endo disorders in childhood. There's a misconception that diabetes only develops at certain life stages. But no, you can get diabetes at any age. Newborns, they can be born with type 1. So age is not, a clear definition for type 1 diabetes. The prevalence of type 1 is much greater than type 2. So historically, type 1 was referred as juvenile diabetes mellitus and type 2 as adult onset. Diabetes can also be secondary to other conditions. So chronic illness and infections. It can develop secondary to cystic fibrosis, Cushing syndrome, severe infections. What about genetic syndromes? So it's also associated with Down syndrome, Klinefelter syndrome, Turner syndrome, and then also gestational diabetes. How it occurs during pregnancy. So infants born to moms with gestational diabetes, they're at a higher risk for hypoglycemia right after birth. Type 1, so this is primarily an autoimmune disease characterized by insulin deficiency. So because of this autoimmune destruction, that is what results in that lack of insulin being produced. So this has no relevance to a child's weight, their diet, or exercise pattern. So even though it can be diagnosed at any age, the onset typically occurs around puberty. And then cause, so hereditary factors, it's tied to genetics. They must have this genetic predisposition for the autoimmune disorder to occur. That with environmental triggers. So having that genetic trait isn't always enough on its own. An environmental trigger like an infection, it activates that autoimmune response. And then type 2 diabetes, this is primarily characterized by insulin resistance. How I mentioned earlier, historically it was considered as adult onset, but it's becoming more common in children because this closely tracks with those rising rates of childhood obesity. There are key risk factors. So having a parent or relative with type 2 diabetes, that increases their risk. If they were pregnant at one point and they have a history of gestational diabetes, or having parents who experience gestational diabetes while being pregnant with them, that's a strong predictor. High risk demographics, so this affects certain racial and ethnic groups as listed on your PowerPoint slide. Clinical signs, if they present with acanthosis nigricans, that is an indication of insulin resistance. Hypertension, that is a common co-occurring condition. If they have abnormal lipid levels, if they're diagnosed with polycystic ovary syndrome, that is also strongly linked to insulin resistance. So pathophysiology of type 1. So this process begins when, how I mentioned earlier, an individual is genetically predisposed and then is also exposed to an environmental trigger. What that leads to is an autoimmune response that targets and destroys beta cells in the pancreas. So the beta cells, the key makers in the hormone factory, since they're being destroyed, they're not producing insulin, and that leads to insulin deficiency. So insulin deficiency, there's no key to open those cell doors for the glucose to enter. So the glucose, it remains in the bloodstream, and that leads to elevated levels of sugar in the blood. With that process, cellular starvation. So even though the blood is flooded with all that glucose, the sugar, the cells are essentially starving because they can't access it, right? The doors are locked. So what the cells do, they signal to the brain that the body needs more sugar because they're not getting access to it, that they don't have it. So the kidneys, they attempt to try to compensate. So they're trying to lower those blood glucose levels in the blood by filtering the blood. When that the serum glucose levels exceed the kidney's threshold, then that excess glucose, it starts to spill over into the urine. And that is what is called glycosuria. Glycosuria, it pulls water out with it, which is polyuria, and that can rapidly lead to dehydration and to the process of diabetic ketoacidosis. Patho of type 2. So unlike type 1, the beta cells in the pancreas, they function fine. They're producing insulin. So it's not due to a lack of insulin, but it's due to insulin resistance. It's often due to weight and dietary factors. So if they're eating a lot of sugar, they have a sedentary lifestyle, those types of influential factors come into your mind that we talked about during week 1, week 2, growth and development. So there's a high demand for insulin to manage that influx amount of glucose. So beta cells, they're working in overdrive. So eventually the body becomes resistant to it. And then a lockout, essentially. So the body it just no longer reacts the way that it should to the insulin. So this process, it takes time to develop. That's why in the past, it used to be adult onset diabetes. So if that high demand and that resistance continue, the pancreas can eventually, fail to produce insulin. And then it'll lead to the pathophysiology of type 1 diabetes and lead to insulin deficiency. All right, so lab findings for both types of diabetes. When they do a fasting blood glucose, those are just when they test their blood glucose levels when the patient hasn't had anything to eat or drink, so no caloric intake for at least 8 hours. So if their results show greater than or equal to 126 milligrams per deciliter, that is an indication that will help with their diagnosis of diabetes. So this is more of a planned screening test. They typically will schedule this for kids that are not exhibiting symptoms. They're typically asymptomatic, who have significant risk factors. So maybe a strong family history, maybe they're showing a high BMI within their growth charts, or they're presenting with those clinical symptoms like acanthosis nigricans. Or a 2-hour plasma glucose. So that's usually measured during an oral glucose tolerance test. This tests how well the body processes that highly concentrated sugar drink over a 2-hour window. So if those results show greater than or equal to 200, that is an indication that'll help with that diagnosis. Random blood glucose. So this is typically accompanied with classic symptoms of hyperglycemia, like that frequent urination, excessive thirst, unexplained weight loss. This is more of that right now test, that first line test that will be done if the child presents to the clinic or the emergency department with classic symptoms. And then hemoglobin A1C. So if the results show above 6.5%, that is that diagnostic threshold. It's more of a big picture test, so it doesn't just show a single moment in time, but over the past 2 to 3 months, give or take, more like 3 months. This is that initial workup. It'll help establish the baseline. Symptoms of type 1. So parents, they'll often report that these develop over a few weeks. So maybe frequent urination, or secondary enuresis. That secondary enuresis, that is a new onset bedwetting in a child that has been potty trained already. This is happening because the kidneys, they're trying to flush out that excess glucose. We talked about it a little bit earlier. So it's pulling large amounts of water with it. Excessive thirst. So the body is trying to compensate, right, for the fluid loss from the polyuria. So the parent might mention like, oh, my kid drinks a lot of water constantly, or they're even waking up in the middle of the night to drink. They may be exhibiting excessive hunger. So since there's no insulin to help with sugar to go into the cells are starving, right? It triggers the brain to signal intense hunger. Other common symptoms, unexplained weight loss. So even though they're eating constantly, they're still losing weight, because since the body can't use the glucose for fuel because it's not going into the cells, it's remaining in the blood, the body is breaking down the fat and muscle to survive, which leads to that weight loss. Fatigue and lethargy. So since the cells are deprived of the glucose, that energy source, it leaves them feeling that unusual tiredness, weakness, that lack of energy that they'll typically have to be able to play. They may have recurrent or stubborn infections. So because of that high blood glucose, it impairs the immune system. It creates an environment where bacteria can thrive. Type 2 symptoms. So most common presentation is they'll be overweight or obese. They'll have a history of being inactive. So many children with early stage of type 2, they're completely asymptomatic. They're not going to exhibit any symptoms usually. It's usually discovered, incidentally during a well child check when their pediatrician runs screening labs based on their BMI and inactive lifestyle that they obtained from their history and physical. But as the disease progresses, then you're going to see more of those clinical symptoms, that hallmark physical sign of severe insulin resistance, the acanthosis nigricans, that dark, velvety patch of skin in those skin folds, the back of the neck, the armpits, the groin. They may develop also the frequent urination and excessive thirst, but it'll be more gradual of how it'll show up compared to that rapid onset in type 1. And just the same like with type 1, since the body is deprived of all that energy, the child will also feel lethargic or unusually tired. And also with the frequent infections or slow healing wounds because of that hyperglycemia. All right, so hypoglycemia, that is low blood sugar that is less than 70 milligrams per deciliter. Often this is a medical emergency. They need immediate intervention. So especially toddlers, younger kids, their symptoms can be more subtle and easily mistaken for like normal childhood behaviors. So that's why assessment and recognition is very vital. So the way that hypoglycemia can present, there are different severities. So the first one, mild, it's more of an autonomic response. So this is when the blood glucose first begins to drop. The body will release adrenaline to try to compensate. So you'll see that fight or flight symptoms. So they may complain of a headache, experience shakiness, feeling dizzy, physical tremors, elevated heart rate, or complaints that their heart is racing. Their skin may be more pale, clammy, sweaty, moderate. So as the brain is starved even more of glucose, you're going to see changes cognitively and behaviorally. So this can be difficult to see in younger kids because this can mimic those classic toddler meltdown, toddler tantrum. So look for unexpected yawning, extreme tiredness, or restlessness. They may exhibit like a sudden irritability. They're frustrated, spontaneous crying, or like just out of character behavioral changes. So they may be confused or even have slurred speech. And then lastly, the severe, this is a neurological crisis. So this is that life-threatening stage. This indicates that their brain is severely starved. This often requires glucagon. So you'll see highly unusual behavior. They may be severely dazed, active seizures. They may just be completely unconscious. And then hyperglycemia, so high blood sugar. So if they are a new presentation, new onset, you'll just follow those ranges on the diagnostic testing slide. If they're a known diabetic, so day-to-day hyperglycemia, it's anything sitting above their target range. It's individualized. Any reading that consistently is just over 180, especially a few hours after a meal, that's considered high, just generally over 180. That usually requires correction. Any reading that's over 240, that is dangerous. That's the danger zone. That's a red flag for diabetic ketoacidosis. So you'd want to immediately test for ketones in the urine. Within this, you're going to see that glycosuria. Since the kidneys reach that threshold, the glucose is going to spill into the urine. Then you're going to see that frequent urination, how the kidneys, since they're flushing all that glucose, they're pulling that large amount of water with it too. The frequent thirst, they're trying to compensate for that polyuria. You're also going to see dehydration signs because of that continual fluid loss. You're also going to see that fatigue and weakness, just like with hypo. And then sensory changes. So because of that high concentration of sugar in the blood, it can cause fluid to pool from the lenses of the eyes, and they may complain of blurry vision. They may have GI symptoms. So it's not just a stomach bug. This can be a red flag for DKA. It may be a sign that the body is burning fat for energy, producing acidic ketones. All right, and diabetic management, we'll go through these more in depth, but this just gives you an overview. So it is a multidisciplinary approach. So if they are admitted in the inpatient setting, can be around 2 to 3 days. But if they are diagnosed with diabetic ketoacidosis, that can be longer. So maybe up to 3 to 5 days. If they're stable and they have access to a good pediatric diabetes team, they can potentially get treated outpatient. So it varies a bit. So within the management is blood glucose monitoring. So blood glucose monitoring, this assesses short-term glycemic control, okay? So a normal fasting blood glucose level for a child that is not diagnosed with diabetes before they eat a meal is that range is 70 to 110. So for those that are diagnosed with diabetes, that range is a bit wider and higher for them. So point of care testing, they use that glucometer and lancets. So how often do we do this? They'll do it in the morning when they wake up, before meals, before bed, so every night, before exercise, as needed, and as needed for any signs and symptoms of hypo or hyperglycemia. So also it includes when they're sick. So sick, that's a physical stressor. It can release stress hormones like cortisol and lead to hyperglycemia. So when they're sick, they need to check their blood glucose levels every 2 to 3 hours. Say if their sickness involves vomiting or diarrhea, they're at a risk for hypoglycemia. So at that point, they need to check it more frequently, every 1 to 2 hours, okay? And then also when they're sick, they need to test for ketones in their urine every 2 to 3 hours. So when they're sick, it increases their metabolism. So that demand for sugar is higher. So if the body can't get enough of the sugar or glucose, it'll break down the fat, release ketones, and it'll lead to DKA. That's why you will test for ketones that often. Also, want to ensure that you educate proper finger stick technique. So making sure that they prick the sides of their finger, not the pads of their finger, because the pads of their finger, they have those nerve endings and it can be more painful. Steps wise, wiping their, first, of course, hand hygiene, alcohol wipe to that area, using a lancet to prick their skin, whether it's an individual one or a pen lancet that they may have once they're discharged. And then wiping off that first sample of blood, because that can be contaminated, right, with any tissue fluid or just the alcohol wipe. Telling them to use that second drop of blood, put it on the test strip of the glucometer. If they're not getting a big enough drop of blood, tell them to drop their arm below their heart. That'll help allow gravity to improve that blood flow to the fingers. Telling them, a band-aid, it's not usually necessary. Just use a cotton ball or like a gauze to apply pressure and wipe away any residual blood. As the child is older and able to understand, they can be involved with this. You can teach them to do it themselves with supervision, of course. The next type of blood glucose monitoring is continuous glucose monitoring systems, so CGM. There are two types on this slide. So the top left corner, that is a Dexcom, and then on the bottom right, it's a Freestyle Libre. So these devices, it contains a needle at first to puncture the skin and insert a sensor that'll sit underneath the skin. So it'll usually be on their arm or their stomach. It'll provide constant blood sugar readings. And within that, it'll show trends, up or down with arrows. So with the Dexcom, the top left corner picture, it'll automatically send those readings to their phone or some type of receiver. With the Freestyle Libre, the bottom right corner, they'll have to swipe their phone or a specific reader over the sensor to get the reading. So with these, it eliminates, that constant poking. It can promote that sense of normalcy for them, not having to remember to bring supplies wherever they go to be able to prick their finger and check their blood glucose. But also, as they're older and they're recognizing like, oh, they're different from their peers, this can cause disturbed body image. Having something that people can see that's out of the ordinary, they may be resistant to have this. Hemoglobin A1C monitoring. So unlike a daily finger stick, not a point of care test, that gives a snapshot of like what's right now. The hemoglobin A1C, that tells what overall glucose control has been like over a longer period. So it's a specific tool to measure to see how much sugar has attached itself to a red blood cell over a 3-month period. So it specifically looks at a 3-month window because the life cycle of a red blood cell is about 3 months. So the goal is for it to, of course, ideally be well controlled, and that means aiming for less than 7%. How often is this checked? Every 3 months. It just aligns with that red blood cell lifespan. It allows the care team to, evaluate, is the current regimen, whether they're on oral medications or injecting insulin, is it working? Do they need to alter the dosing? Do they need to change up their plan? If a child is very stable and they have very well-controlled blood sugars, sometimes the provider may decrease the testing to maybe every two times a year. So it can vary a bit. Oral medications, this is only for type 2 diabetes. This is that primary med that's prescribed initially. So it works in two different ways. For one, it works to decrease the production of glucose, so specifically in the liver. It stops it from dumping extra sugar into the blood. And secondly, it works to increase glucose uptake, basically. So it makes the body more sensitive to the insulin it's already producing. There are potential adverse effects as listed on your slide there. The GI issues, like flatulence, along with maybe nausea and diarrhea, those are the most common reasons a child wants to stop taking this medication. So educating family and that patient to take metformin with meals, that can possibly minimize some of that stomach issues. But if this medication fails to control their blood glucose levels, then the treatment plan will step up to insulin. So insulin therapy. We always give insulin in units. How often do we administer insulin? So we'll do rapid acting insulin right before meals, and every night we'll do long acting insulin. And we'll go over the different types in a bit. Standard administration, it's typically injections, but with new technology, they also have insulin pumps available. So with injections, we always inject in a nice fatty area, so subcutaneously. If we're going to do it in the stomach area, making sure it's about 2 inches away from the umbilicus. They can do their outer thighs, back of their arms, right above their buttocks. So there's like a little fat pad there. So not on the butt cheeks themselves, right above it. Making sure that you educate for them to rotate sites because you want to prevent lipohypertrophy. So insulin, how it's absorbed in the skin, if you always do it in one area, that tissue will start to thicken and it'll decrease absorption of the insulin. But children, they often choose the same location out of convenience, whether it's because, they're right-handed or it's just hard to reach the back of their arm. So they always gravitate towards the right side of their stomach. So being able to educate about that. Also, injection technique is very important within the steps, hand hygiene at first when they're at home too, alcohol wipe, pinching the skin, then injecting at a 90-degree angle. Describe it as like a dart, 90 degrees. When the needle is in, making sure that they release that pinched skin because you want to allow the insulin to be absorbed, not squeezed out. Because if you remain squeezing it, once you take out the needle, you're just letting the insulin's not going to be absorbed properly. Once the needle is in, make sure that they count for 3 seconds. And then calculating, that's very important too, which we'll be going over. But first, the different types of insulin. So there's 3 different phases of how insulin behaves, basically: onset, peak, duration. So onset, it tells you when the child needs to eat. So what it is, how long it takes for the insulin to enter the blood and lowering the blood sugar. So if, for example, if you give a rapid acting insulin, which has an onset of about 15 minutes, the food tray, it must be in the room and the kid must be ready to eat. If the food tray was delayed like 45 minutes, that insulin will start working without any carbs being ingested. So their blood sugar will crash. If you give the insulin too late and they already started eating, the food will hit their bloodstream before the insulin. So that'll cause a spike in their levels. The peak, that tells you when to assess for hypoglycemia. So the time when insulin is at its maximum strength, basically, working its hardest to lower blood glucose levels. So this is that window of their highest risk for hypoglycemia. That's why it says danger zone. So knowing peak, it tells the nurse and parents to know exactly when to be most vigilant, basically. So say if you give an intermediate acting insulin, which peaks at about 4 to 12 hours. So you give it at 8 a.m. So the nurse or whomever knows to watch that child closely between 12 and 8 p.m. So say if that peak coincides with when they're in gym class, then there needs to be an action plan involved when they're at school that child may need a complex carb snack right before they start gym class to prevent hypoglycemia. And then duration, it tells you when the patient needs their next dose. So how long the insulin continues to actively lower the blood sugar before the body clears it completely. So this basically kind of like dictates the dosing schedule, and it prevents the gaps in coverage. So it helps kind of prevent insulin stacking. So for example, like say if you give a dose of short-acting insulin that has a duration of about 8 hours, if the physician orders another dose 3 hours later for a high blood sugar reading, usually like the nurse must recognize that the first dose is still actively working. And then now the different types of insulin. So you will need to know the different types and the different onset peak duration. So for ultra rapid and rapid acting, that is, think of it as the sprinter in running terms for runners. Common examples of this is Humalog, Novolog. Think of these insulins as a 100-meter sprinter. So they burst out almost immediately. They hit their top speed very quickly, but then they become completely exhausted and done within a few hours. So onset is very fast, lightning fast. It peaks early and it's gone in a few hours. So this type of insulin, it matches the process of digestion. So when giving insulin, the child must have their food right in front of them or be actively eating. This is why it's important for them to have well-balanced meals, because a simple carb, or it's also called a fast-acting carb, say like a sugary type of cereal, that contains little to no fat or protein. So it'll break down faster in the body. And then the sugar will be available faster in the body as well. So when insulin peaks in 1 to 3 hours, the body is out of things to give sugar. So they're at risk for hypoglycemia. Versus if you're giving them a well-balanced diet with complex carbs that include, like whole grain toast, maybe yogurt, eggs, fruit, it breaks down slower. Short-acting insulin, so think of this as the 5K runner. So an example of this is regular insulin. This is, how I said, the 5K runner. They take a little more time to stretch and warm up before they start. They pace themselves through the middle, then they run a bit longer compared to the sprinter, compared to the ultra-rapid and rapid-acting insulin. So onset is about 30 to 60 minutes, peaks 2 to 4 hours, lasts about 5 to 8. So in the clinical setting, if you give this medication, this type of insulin, it's given IV for patients that are diagnosed with diabetic ketoacidosis, because it allows for safe titration of it and prevents any drops in blood glucose levels. Sometimes this is given if a family can't afford rapid acting insulin. It is a little bit more inexpensive. Or maybe if they're on continuous enteral feeds, so G-tube feeds or TPN. So sometimes their feed, it's like continuous. So it could be like an ongoing stream of carbs basically. So this has that slightly slower onset, longer duration. So it provides more smoother, more sustained coverage versus the burst of like rapid acting insulin. This one is not used for meals because the onset takes too long, because it takes 30 to 60 minutes to start working. So then the kid would have to get an injection and wait up to an hour to eat. So because of And then intermediate acting insulin. Think of this as the 12-hour shift worker. An example of this is NPH. So the 12-hour shift worker, this is that hospital shift worker, or say a nurse, takes them a couple of hours to commute. They clock in, then they do their heaviest work right in the middle of their shift, and then they clock out after about 12 hours. So this type of insulin, it works well for younger kids whose eating habits are unpredictable. Think about how, remember we discussed toddlers are grazers, like they don't eat large sets of meals. So since this type of insulin takes about 2 to 4 hours to kick in, it has a more broader peak, lasting about 4 to 12 hours. This acts as that continuous safety net. So if a toddler grazes on a small amount of carbs all morning and afternoon, that wide peak, the 4 to 12 hours, it covers that continuous snacking. So without that child needing to be poked with a needle for every single little graham cracker that he or she eats. Long acting, think of this as the background music. So a common example of this is Lantis. So this is that background music in a restaurant. It's steady and has a continuous volume all day and night without ever getting suddenly loud because it has no peak, right? So this provides what is called a basal rate, a continuous small amount of insulin that the body needs to keep fasting blood sugars stable. Keep fasting blood sugar stable, even when the child is fasting or sleeping. So because there's no peak, it rarely causes hypoglycemia on its own. So I know I mentioned that you do need to know the different types and the onset, peak, and duration. So you need to know rapid acting, short acting, intermediate acting, and long acting. So with ultra rapid, you don't have to memorize the onset, peak, duration. Just be aware of it. And then for the long acting, I know there's different onset, peak durations based on the type or the brand. So just do Lantis, okay? All right, let's talk about insulin pumps. So think of the insulin pump as the external pancreas, so to speak. So unlike standard insulin injection regimens, where they're prescribed a long-acting and a rapid-acting, the pump only uses a rapid-acting insulin. The insulin is stored in the device, as you can see in those two pictures. So it administers that basal rate, that steady drip, a tiny, continuous 24/7 infusion of, again, that rapid acting insulin. It's trying to mimic that natural insulin release of a healthy kid's pancreas, basically. And within that device, it administers those bolus doses for meals. So when the child is ready to eat, the parent just inputs it's preset to the insulin to carb ratio, whatever's prescribed, and they input the carbs of what they're eating, and the pump will automatically calculate and administer the exact dose needed. So now there's more advanced features as well. So more modern insulin pumps, they can connect directly to those continuous glucose monitoring systems that we talked about in the previous slides. So it'll have that internal algorithm that watches the blood sugar trends. So if the monitor system notices the blood glucose trending lower, the pump will automatically decrease or slow down that basal rate. So it's just trying to prevent hypoglycemia. Advantages to this is that it minimizes injections. Rather than 4 to 6 needle sticks a day, it's just one needle poke every about 2 to 3 days when they have to change the infusion set. So it can result in less physical and less psychological trauma. This provides that sense of normalcy for them. Let's talk about diet. So within the management plan is to have a well-balanced diet. When you eat, that's when digestion starts. So the more and more sugar, nutrients come available to the body, some quicker than others, right? We talked about the simple fast-acting carbs and then the complex carbs. So just depending on what you're eating. So children diagnosed with diabetes, they need the same nutrition as any other growing child. So they just need their insulin matched to it. Okay, so we want to focus on moderation, teaching balance with the MyPlate method. So the picture to the top left corner, the one with the purple background, shows an example of a meal that is well balanced. It shows how many carbs per food group as well. So what about sweets? Those should be limited, not totally restricted. So if these kids see their peers eating candy from Halloween, Valentine's Day, Easter, and they're restricted on it, like they can't have it at all, this is what can lead to binge eating or sneaking food. And that's dangerous, right, for that blood glucose control. Teaching consistency. Consistency is key. Emphasizing that importance of consistent food intake. So warn against skipping meals because that can cause hypoglycemic episodes. For new onset diabetics, a registered dietitian or a dietitian consult will be ordered, they will help teach carbohydrate counting, how to look at food labels to assess for carbs with how many servings. So that picture to the bottom left shows that. Of And then also the picture on the right, it shows different foods of what one serving is about 15 grams of carbs. That's standard. They'll also educate on, okay, what's a simple, fast acting carb? That's like what? Candy, juice. It's easy for the body to break down, right? The amount of sugar available will be immediately higher. And educate on complex carbs. That could be like pasta, a pasta dish, or turkey sandwich. It's high in fat and not so much sugar. This takes the body longer to break down, and the glucose release is slower. And then often, again, if it's a new onset, they'll advise them to track their blood sugar patterns related to the meals that they're eating. So initially, they will have like a food diary or a food log, um, either for maybe a few weeks, few months, or however long. All right. And then also, um, for kids, for carb counting. So kids that are younger than 6 years old, we give rapid acting insulin, like or Humalog, an example that's common, after they eat, not before. So that's postprandial dosing, post meal. So we do this because younger kids, how we talked about earlier, how they can be unpredictable with their eating habits. So insulin is dosed based only on the exact carbs they actually consume within the 30-minute window we allow. So, say for example, a child might be super excited to eat a sandwich that they see on their meal tray if they're admitted. They take 2 bites and then they decide to just completely refuse to eat it because the crust is not cut, or they just decide not to eat it. We also do this because we want to avoid hypoglycemia. So, say we give rapid acting insulin before the meal, expecting that that kid will eat the whole food tray, which was like 45 grams of carbs. So, you gave them insulin to match that 45 grams of carbs, but then the child only decides to eat 10 grams of carbs. Then that nurse just administered an excess amount of insulin that you basically overdose them. That insulin will peak quickly, but there's no glucose from the food to match it because they didn't eat enough. So that can lead to that dangerous crash. Um, so in the inpatient setting, kind of the process of how we would do it, the food trays, they're given to the nurse's station. They don't present it, and like they don't deliver it into the patient's room. That's just standard. So it's the responsibility of the nurses to check everything on that meal receipt that's on the food tray. Whatever is listed on that meal receipt is on that. The food is actually on the food tray because you want to prevent any over or under carb counting. After you check that, then get the supplies real quick, right? Glucometer, lancet, cotton ball, alcohol wipes. So you'll get that, the food tray, then go into the patient's room. You'll take their pre-meal or pre-prandial blood glucose, a point of care test. And then they will already know ahead of time, or you'll tell parents, okay, now you allow them to eat for 30 minutes. So tell them like, okay, at 8:30, you have to, you only have until 8:30 a.m. to eat your breakfast. So making sure parents are aware of that ahead of time. So after that 30 minutes or closer to that 30 minutes, count how many carbs they ate from their food tray. Calculate how much insulin you're going to give based off of the meal, and then calculate how much insulin you're going to give based off of their pre-meal blood glucose level. And then you'll kind of refer it to the sliding scale, which we'll show and we'll talk about in a little bit. After you calculate them both, draw it up, 2-hour in check, then you administer. So that 30-minute window that is given, it ensures that the rapid acting insulin can still catch up to the carbs being eaten. So you may be thinking in your head, it's like, oh, but rapid acting insulin or Humalog has an onset of 15, 20 minutes. But if we allow the kid to eat for 30 minutes, then give insulin, which takes another 15 minutes to kick in, isn't the blood sugar going to spike? And honestly, the answer is yes, it will spike. But in peds, for these younger kids, we accept that trade-off. So we don't want to overdose with insulin and cause severe hypoglycemia and leading to a life-threatening emergency to where now they have seizures, a coma, brain damage, versus, a temporary post-meal blood sugar spike, right? That's not ideal, of course, but it's not immediately lethal, right? So basically, choosing a temporary high over a potentially fatal low blood sugar. And also think about how the body breaks down different foods at different rates, right? Simple sugars available immediately. Complex carbs, proteins, fats, that takes longer to digest and impact that blood glucose level. So therefore, that 15-20 minute delay of the insulin that's administered, it can often catch that tail end of the meal's digestion anyway. So a great rule of thumb is you can always give more insulin later, but you can never take it back once it's injected. Usually around 5 to 7 years old is when we can start to administer insulin prior to meals. We won't do the postprandial dosing. We'll give the insulin for that correction bolus for the pre-meal blood glucose level and that food bolus for the meal that they're going to eat. So I gave that range 5 to 7 because providers look at them developmentally and their behavioral consistency. Are they reliable, or are they a new onset diabetic that's still learning the process? Parents too. You'll be able to get more information during change of shift too, or the day prior, or looking at the notes to see what was done before. But yeah, so it can differ. Some hospitals may have different policy, but generally younger than 6 years old is when we do the postprandial dosing. When they're over 6 years old, 6 and up, then we'll do pre-prandial dosing. So we'll give the insulin before their meals, just like we do with adults. So that's very important to know. So here is an example. So on the left-hand side, this can be like their insulin regimen. So say this is for their lunch. It shows, okay, we're going to give him Humalog, the rapid-acting insulin, for their insulin to carb ratio. So for every 10 grams of carbs that they're going to be eating, we want to give 1 unit of insulin. So a 1-to-10 ratio. And so when you see and, you're adding it. So the sliding scale, that is for what is their pre-meal blood glucose level. So based on what their level is, then you'll give that amount of units. The right-hand side, that is an example of that meal receipt that you'll be given with the food tray. So as the nurse, it's your responsibility to double check. Everything that's listed there, is it on the food tray? If it lists like, there's 2 wheat rolls that's listed on the meal receipt, then make sure that there's 2 wheat rolls on the food tray. And then also on the bottom of that meal receipt, it shows the total carbs. Don't just trust that. You need to add it yourself. Add all the different carbs, like how many grams per food item, so that you double check. Don't just rely on the total carbs at the bottom, because there can be some mistakes, right? So when I would do this, I would use like the back of the receipt to write down everything. So once you take their point of care tests, I know you can still have it on the glucometer, but just writing it in the back and doing all of your calculations that way, so that when you write down, okay, what was their pre-meal blood glucose level, and then how much are you giving for the meal, when you divide it and everything, then you can show the nurse that you do the check with, and they can do their own calculation and compare it to yours, and then they'll sign it off. So let's kind of practice here. So say we're going to use this meal receipt and the insulin regimen together. So say the kid is like 8 years old. So we're going to do the pre-prandial dosing, meaning we're going to give the insulin before meals. before the meal, before they start eating. So they say, okay, they like everything, they're going to eat everything on the tray. So you add everything on the meal receipt, double check it, it's 86. So they're going to be eating 86 grams of carbs. So look at the insulin regimen. Again, it's 1 to 10. So what's your desired? It's 86 grams. What do you have? It's 10 grams. So 86 divided by 10. That is what? 8.6. So you're going to be giving 8.6 units of Humalog for their meal. Say their blood glucose level, you pricked them or they did it themselves, it's 180. So take a look at the sliding scale. Where does 180, what range does it fall within? It's that 151 to 200 range, right? So then you're going to give 2 units. You're going to give 2 units of insulin for their blood glucose level. So 8.6 plus 2, how much are you giving in total? It's 10.6 units, right? All right, that's an example, and we'll have another practice question in a bit. Let's move on to exercise. So main thing, kids, they should be able to play. You know, children with diabetes, they're not restricted from playing sports or exercising. Just like any other child, they should aim for about an hour of physical activity per day. Okay, so regular exercise, that promotes healthy weight and it can ultimately help with that long-term blood glucose control. Things within this management or within exercise, monitor and preparing. So exercise, it can cause hypoglycemia, and in some cases it can cause hyperglycemia. So because of this unpredictability, you want to be able to check their levels before, during, and after physical activity. So ideally, that safe range for a child before they start exercising, you want it to be around 126 to 180. Also, you want to ensure that they have access to emergency supplies, meaning they have access to fast-acting carbs, simple carbs, a juice box, a glucose tablet, soda, not diet soda, not Coke Zero, soda that has sugar, able so that they can treat a hypoglycemic episode if it occurs. Red flags. So when is it not safe for a diabetic kid to exercise? So if their blood glucose level is over 240, hold exercise. If they have large amounts of ketones in their urine, hold exercise. If the kid, those are both signs of DKA. So if the kid is already in ketoacidosis, adding that lactic acid that's produced from exercising, that can push their body into like that life-threatening metabolic acidotic state. So that's why we hold exercise for those two. Okay, how do we manage hypoglycemia? So we talked about how hypoglycemia, it's less than 70, right? So giving intramuscular glucagon or IV dextrose, those are emergency interventions, okay? That's when a child isn't able to eat or drink by mouth. These kids, it's because these kids may be unconscious, maybe they're actively seizing, or they're just too lethargic to swallow, and then that leads them to a risk for aspiration, right? So that's why we would give an alternate route. So for IM glucagon, this is just basically a hormone. It forces the liver to release that glucose into the blood. This is more so in home, school, sport settings because they don't have IV access. If they do have IV access, like say in an inpatient setting, we'll give IV dextrose, like D10. So that's pure glucose. They administer that into the bloodstream. If it's not that emergency situation where they are able to eat and drink, then we'll do the 15-15 rule. The 15-15 rule, you need to know this, okay? So the criteria to even start this, because there's steps to it, one, they need to be awake and able to drink or chew. They need to meet that criteria. Okay. Then if they meet that criteria, you do a point of care test. You check their blood glucose level. If it's less than 70, you proceed with the next step. If it's less than 70, you give them a fast acting carb. You give them a simple carb, 15 grams. So with that 15 grams, it depends on how old they are. So if they're older than 4 years old, you give that 15 grams. If they're younger than 4, you give half of that, so 8 grams of sugar. And then it gives you an example of the measurements of like, okay, if you're going to give them juice, how much juice, soda, glucose tablets. Then after you give them that carb, depending on their age, how much you're going to give, whether it's 8 or 15 grams, you wait 15 minutes. After that 15 minutes, you're going to check that blood glucose level again. If it's less than 70, you're going to repeat the steps again. Repeat 3, 4, and 5, 3 through 5. You're going to keep repeating it until their blood glucose level is over 70 and above, okay? Then you stop. After their blood glucose level is 70 or above, then you want to give them a complex carb within an hour, okay? That complex carb, after they reach that criteria, say if they don't, if you don't give that, you remember you gave them just like straight sugar. Then that blood glucose level will decrease again, because it'll peak then go down. So that's why you want to give them a complex carb. Think of like a turkey sandwich, okay? So again, you need to know these steps. Next is self-management. So the goal overall is, as they start to get older, for these children to be able to care for their diabetes on their own. So educating to the child and parents or caregivers. So what's involved within this? What's the process? So diabetic education. So a diabetic educator, typically it's a nurse, but they specialize in this education. And then an RD, registered dietitian. They both will educate to parents or their caregivers, whether it's like mom and dad, or say if it's grandparents that are legal guardians, whoever's their sole caretaker. And also the child too will be involved. They need to have diabetic education and RD before they're discharged. Again, they're going to go over like food labels, diet, food logs, carb counting, insulin calculation, point of care testing, and insulin injections. Also within this, so that they can manage this safely on their own when they're home, is that they need to have all the supplies before they're discharged. Okay, so often at hospitals, they need to have it delivered, or they need to have it in their hands before they can leave the unit. So it includes a glucometer, lancet, insulin, and then also think about, do they need duplicate supplies of these? Do they live in 2 households? Say parents are divorced and they both share custody. So to prevent any gaps in care, and sometimes psychosocially too, you may never know, they may be very appropriate at bedside, but if something happens and they choose to weaponize their child and withhold medications or supplies from the other parent, that can cause the child to go into DKA or cause any complications. So case management or social work wise too, that may be considered to have 2 supplies, and depending on insurance, I believe too. And then also the bedside nurse is involved in this. They help with education. They supervise and guide parents. So you want to ensure that both parents or whomever the kid resides with, they demonstrate this. They demonstrate it at bedside at least 2 times prior to their discharge, so that you can see, can they calculate? Can they carb count correctly? Can they count the insulin correctly? Can they draw it up? Do they know the process? Do they know how to rotate sites? Do they know which sites to inject? If the child is older and involved, then they need to demonstrate it as well. And then also making sure that they're aware of, okay, what's the action plan for any hypo or hyperglycemic episodes? Making sure that they can teach back to you, recognizing signs of these. How would they treat it at home? And then sick day rules. Again, remember they need to check their blood glucose levels every 2 to 3 hours, every 1 to 2 if they have diarrhea or vomiting. And if it's elevated, remember again, checking ketones for every 2 to 3 hours until it's clear. And then advise them, to contact their provider for guidelines, whether it's their primary care provider or endo, whatever is within that action plan. And then also educating on complications and signs of diabetic ketoacidosis and hyperosmolar hyperglycemia non-ketoacidosis, HHNK. So DKA, that's more common for type 1. HHNK, not as common, but seen more in type 2. Okay, practice problem. So the patient's ordered insulin regimen is indicated below. The patient is having 55 grams of carbohydrates for lunch, and his blood sugar before lunch is 199 milligrams per deciliter. So how many total units of Humalog will the nurse prepare to administer to the patient prior to his lunch? Record your answer in units and round to the nearest tenth. So practice. Pause right now, write it out, try to calculate it on your own before going on to the next slide and before continuing on with this lecture. All right, so let's calculate the meal. So it says that the child is going to have 55 grams of carbs. What is the insulin to carb ratio? It says 1 unit of Humalog for every 10 grams, so 1 to 10. So what is your desired? It's 55 grams. What do you have? 10. So 55 divided by 10, you should have gone 5.5 units. So you're going to be giving 5.5 units of insulin for their meal. So what was their pre-meal blood sugar level? It was 199. Look within the ranges, the sliding scale. What does it fall within? You should have seen that it falls within the 151 to 200 range. So you will be giving 2 units for their blood sugar level. So take how much insulin you're going to be giving for their meal and how much you're going to be giving for their blood glucose level, add it together, and you should have gone 7.5 units. Double check, it says to round to the nearest tenth. It's already in the 10th place, so you're good. You don't have to, there's no trailing numbers after that 5, so then you don't have to round. So 7.5 units is your final answer. All right, let's talk about diabetic ketoacidosis. This is a severe PEDS emergency. If this is not corrected fast enough, this can lead to death. Okay, so why does it happen? This typically comes from two main scenarios. So one, when a child's diabetes goes completely unrecognized. So per American Academy of Pediatrics, it says about 40% of kids are not diagnosed with diabetes until they have already progressed into DKA. Or the second scenario is when there's poor management of an already known diabetic. So maybe they're missing insulin doses, or they don't know how to properly manage their diabetes when they're sick. Being able to get a more history on it. Is it financial reasons? Do they need more education? What is it? What's causing it? But those are the two main scenarios. Pathophysiology-wise, think of a domino effect. Okay, this begins with hyperglycemia. So insulin isn't available because you know how I mentioned this typically, it's more common for type 1 diabetics. So insulin isn't available. The cells can't use the glucose. Cells are starving. All the while drowning in sugar in the blood. So the kidneys filtering the blood. Once it reaches that threshold, right, it'll spill into the urine, glycosuria, all the amounts of fluid with it, causing dehydration. And then now the body is desperate for fuel. So the cells begin to break down protein. So the liver takes that broken down protein and converts it to even more glucose. And that leads to pouring more sugar into the bloodstream. So while that's happening, the body is also breaking down fat for energy. That's what causes that weight loss. And a byproduct of that is producing ketones. And that's very acidic. Ketones, then they're going to enter the bloodstream. It's going to lower the pH of the blood, and that produces ketoacidosis. The body tries to compensate, and it'll dispose those ketones through the urine. So you're going to see ketonuria, and through the lungs. You're going to see Kussmaul respirations. They're going to have a fruity smell to their breath. At this point, the brain is starving, so it requires sugar to survive, right? So that state of being deprived, and then also that acidotic state, that can eventually cause the brain to shut down. So that combination of severe dehydration, high blood glucose, the acidic ketones circulating in the blood, that leads to that metabolic crisis of DKA. So symptoms of DKA, GI and dehydration signs. So this is often misdiagnosed for like a stomach bug or appendicitis. They often will present with anorexia, unexplained nausea and vomiting, severe abdominal pain. So because the body is flushing out all the fluids to get rid of the sugar, showing those classic signs of dehydration, you might see decreased skin turgor, right? As a result of all that fluid loss, they'll develop that elevated heart rate, right? That heart is working overtime to pump the decreased volume of the blood. What about respiration and acidotic signs? Those are hallmark cues. The child's breath is going to have a very distinct fruity or acetone smelling odor to it. That's a sign that the body is breaking down the ketones. The Kussmaul respirations, that is like rapid breathing, rapid hyperventilation. They're trying to blow off that excess carbon dioxide, since that's acidic, to compensate for that metabolic acidosis. And then neuroscience, that's that danger zone, because the brain is severely dehydrated, swimming in that acidic blood, and results in their level of consciousness becoming altered. You're going to see behavior changes, the confusion, profound lethargy. If these symptoms are not recognized and treated, rapidly, the brain will continue to shut down. They're going to progress to a coma and ultimately result in death. So management. So there's typically different steps to it, or goes in different steps. So step 1, they're going to be admitted inpatient, and you want to do fluid resuscitation. So first priority is to restore that intravascular volume. So typically they'll be prescribed 0.9% normal saline. They'll give that initial fluid bolus before insulin. Say if you give insulin too early, or you're dropping the blood glucose too fast, that can cause that shift of water, cause the water to travel or shift into the brain cells and cause brain swelling. So you don't want that to happen. So that's why we do fluid resuscitation first. Then step 2 is continuous IV insulin. So about maybe after an hour, start the continuous IV infusion of regular insulin. Remember, short-acting insulin. It's a slow, steady drip. It helps safely lower those blood sugar levels. It'll help stop the body from breaking down fat for fuel and stop producing ketones. Step 3 would be that potassium replacement. So sometimes once they're admitted, when they get labs done, they may show like a normal or a high potassium level. But once they start infusing the IV insulin, this makes potassium go back inside the cells. So it can cause those levels to decrease, to deplete. Step 4, adding dextrose. So once their blood glucose level drops to a certain range, maybe like generally like 250 to 300, then they're going to add dextrose or sugar to the IV fluids. They add that sugar to act as a safety net, basically, to prevent hypoglycemia while the insulin drip is still running, trying to clear the ketones from the blood. And then lastly, neuro checks. So in addition to like the hourly blood glucose checks, they need to do hourly neuro assessments, typically is what's ordered. And that's assessing for cerebral edema, that's swelling in the brain. So it could present as severe headache, confusion, a drop in heart rate. Maybe they have sudden incontinence or lethargy. So usually that'll prompt the nurse to stop the fluids and contact the team, contact the physician. Lastly, long-term complications. So now let's shift the focus from acute emergencies like DKA to more slow-moving damage because of that prolonged hyperglycemia. So when blood sugar is constantly high, the blood becomes thick and syrupy. This makes it difficult for the blood to pump through that, quote unquote, the body's plumbing system. Okay, it can cause problems with circulation and essentially block the blood vessels and cause nerve damage throughout the body. So, because their circulation is compromised, these kids are at a higher risk for poor wound healing and recurrent infections. There's two different types of damage, microvascular and macrovascular. So microvascular damage, think of the small pipes of the body's plumbing system. So that thick, sugary blood, it blocks the small blood vessels first and affecting that microvascular system. So damage in the eyes, damage to the filters in the kidneys, nerve damage in the extremities, the large pipes, so macrovascular damage. So over a long period of time, those larger vessels will be damaged. It'll lead to more broader complications, heart attacks, stroke, peripheral vascular disease. But that type of damage requires high sugars for a long period of time. So those types of organ complications, they're seen more frequently in adults. So how do we manage this? So this slide and the next slide, you don't have to memorize. I just want you to be aware that there's a schedule and a plan. So to ensure monitoring and managing these complications, there are specialists and tests that are done. And again, these two slides show that. It just shows how these complications are addressed in diabetic management. And that concludes this lecture. If you have any questions, please don't hesitate to reach out. And yes, thank you.